Good evening and welcome to WBUR's virtual town hall series on the coronavirus. I'm senior business reporter Callum Borchers. This event is organized by the team at WBUR City Space, where we look forward to hosting you again, or perhaps for the first time in the future. But tonight we're coming to you live on YouTube, Facebook, and WBUR.org. Don't forget to subscribe to the WBUR YouTube channel to get notified anytime we release a new video. You can also click the bell icon right next to the subscribe button if you want to be notified whenever we go live. We're joined tonight via Skype by Dr. Sandro Galea. He's an epidemiologist, so confronting a pandemic like COVID-19 is his specialty. He's also Dean of Boston University's School of Public Health, and his latest book, with co-author Michael Stein, is called Pained: Uncomfortable Conversations About the Public's Health. Dr. Galea, thanks for being with us.
Thank you, Callum, for having me.
Also with us via Skype is Danielle Allen. She directs Harvard's Edmond Safra Center for Ethics. She and her team recently published a document called Roadmap to Pandemic Resilience, which proposes steps toward a social reopening. And she's a contributing columnist at my alma mater, the Washington Post. Professor Allen, welcome to you as well.
Thank you, Callum. Good to be here.
And we're going to focus tonight on two closely related themes. The first is the societal costs of COVID-19 and our efforts to slow its spread. And the second is how and when to let up on some of those efforts, specifically the restrictions on daily living that are causing collateral damage. And viewers, we'd like you to be part of this conversation too. What price are you paying to help blunt the coronavirus? And do you think it's paying off? What do you want to know from our experts about the path forward? You can send us your questions and comments at slido.com using the hashtag WBURVTH4, as in virtual town hall, number 4. There's no need to download an app. You can do it right in your web browser. And if you're tuning in on your computer or tablet, you can use your smartphone to submit a question without missing a moment on the bigger screen. We've already received some excellent questions, and we'll get to as many as we can in the next hour. Also, check out the YouTube live chat to talk to others who are watching and exchange ideas. All right, Dr. Galea, I'd like you to get us started by expanding on something you wrote recently in Scientific American. You say that many of the measures we're taking to combat the coronavirus are necessary, but you also say, quote, the solution we are adopting is not cost-free. What do you mean by that?
Well, I think in some respects, I'm stating the obvious, that shutting down whole economies results in enormous economic consequences. Now, I'm looking at this from the place of health, from the perspective of health. So there is this irony that we are acting on a public health emergency, and presumably we are doing that to minimize the health consequences. But by incurring these economic and social consequences, we are incurring health consequences both in the present and in the future. We know, for example, that recessions are associated with physical health and mental health consequences. We know that suicide rates go up when the economy is not doing well. We know that depression, post-traumatic stress goes up. And we also know that depression, post-traumatic stress are associated then with heart disease and with lung disease and with cancer. So we are creating the conditions for worse health in the medium term and in the long term. And just to hone that a little bit, part of the challenge is that these economic consequences are not being borne evenly, that they are not shared across all of society, that it is those who are less stably employed, whose work does not have sick time, who are less stably housed, who have less access to nutritious food, those are the ones who are going to be most affected by these economic consequences. So I wrote that piece, and it was part of a companion piece that I had written in Scientific American earlier, to draw attention to the fact that there are real consequences of this event that are going to accrue more to people who are marginalized and less stably housed and have less stable income, number one. And number two, that the approaches we have taken to the coronavirus, those approaches in and of themselves are going to have their own consequences. And we need to balance both when we think about the right approach to the coronavirus. It's been distressing in the public conversation to see this polarization of discussion, that there has been a blue discussion, so to speak, that has said we should protect public health at all costs, and the red discussion, so to speak, that says we should be opening up the economy at all costs. But I think that dichotomy is a false dichotomy. It really is a false dichotomy that's born out of not understanding the complexity of the moment. Of course, we need to make sure that we contain the coronavirus. That's why I said that. That's why I said that a lot of what we've done has been necessary in the short term. But it strikes me as equally well, of course, we do not want to create the kind of crushing economic consequences that are themselves going to have enormous health consequences. And what I was trying to do in the piece is to say both are important, and we owe it to ourselves to have a mature discussion about the full range and the full burden of consequences of the coronavirus and of the consequences that we are trying to put in place to mitigate the effects of the coronavirus.
Well, Professor Allen, I think that the high cost that Dr. Galea is talking about is exactly why so many people are really eager to ease up on physical distancing, business closures, and some of these other restrictions. But in your group's Roadmap to Pandemic Resilience, you warn that, quote, what we need to do is much bigger than most people realize. We need to massively scale up testing, contact tracing, isolation, and quarantine. So fill in some details, if you would. I mean, what would that massive scale up look like in your view?
Sure. Well, let me please start with the point the Dean was making. It's exactly right that we started out with this sort of sense of these two opposed pathways. One, which was about letting the economy be open and letting disease counts just run wherever they were going to run until we hit herd immunity. We call that pathway surrender, and it's important to recognize actually that in sheer economic terms, it's actually the most expensive policy path. So the numbers of deaths, 2 million deaths, actually counts as a sort of hit to the economy of $15 to $20 trillion. That's actually the most expensive path. And then there's the path about freezing everything down and just keeping things frozen until we could get to a place of having a vaccine, or lifting restrictions, putting that down again and so forth until we got to a vaccine. That's also super expensive for exactly the reasons that the Dean articulated. So we really did need a solution, as he said, that permits us to align our objectives, simultaneous objectives of saving lives and saving livelihoods. And the relevant path for doing that is mobilizing the economy to scale up testing, contact tracing, supported isolation, where the point of those is that those are the tools that permit you to interrupt chains of transmission. So we do have hotspots like New York, Boston, for example, where containing the disease at this point is extremely, extremely hard. We're really sort of in a state of mitigating it. But most of the country absolutely still has within its range actual full suppression of the disease, clearance of the disease from the country. And if we focus on doing that and then return to clearing the disease from red states as well, we would actually be mobilizing the economy to save lives. So we'd be able to open up a lot of the economy already. There's sort of parts of the economy that should be open where prevalence is very, very low. We have sort of three different kinds of locales in the country, sort of almost zero prevalence locales that are where the active virus presence is below 1%, and locales where the prevalence is over 1% of the population. There's lots of room for opening in those sort of no prevalence or low prevalence areas. And then, so we need a different kind of strategy in the high prevalence areas. But across the board, if what we really could do is mobilize the economy to ramp up the testing supply chain, we would give ourselves a tool of disease control just as powerful as stay-at-home orders, but which does not actually also kill the economy. So that's the goal. We had one tool for controlling the disease, collective stay-at-home orders. Unfortunately, that's a tool that also kills the economy. So it's really incumbent on all of us to invent a new tool for disease control, which is, again, really, 5 million tests a day was our sort of target number for what it would take to actually control the disease and to be able to move away from stay-at-home orders while controlling the disease.
That's 5 million nationally you're talking about.
Nationally, exactly. It's an aggregate number. And it really is, that's one of the hard things, is that you have to then break the picture out and really be clear on what that means, again, in those sort of three categories of close to zero prevalence, low prevalence, and high prevalence. And so different places need different levels of testing. The bulk of the need, if one were sort of really truly taking it in an aggregate context, is in those sort of red hot zones. Given testing scarcity, there's a sense in which what we should really be doing with our tests is really focusing on completely suppressing the disease in our sort of no prevalence and low prevalence areas, while also continuing to ramp up our testing capacity so that we can also deliver that strategy, TTSI, as we call it, testing, tracing, and supported isolation, to the hottest zones.
Let me just ask you on the news of the day, though, Professor Allen, because we saw, I think, a little bit of what you're talking about today, where the governor a little bit early eased up on some of the restrictions on non-essential businesses. His order doesn't expire until May 18th, but as of today, some businesses that are on the non-essential list can bring back a few employees. They got to maintain a lot of social distance within the workplace, but they can start to process online or phone deliveries and send those out to consumers without making contact with their customers. I mean, is that the kind of gradual transition back into an economy that you're talking about?
It is. And so in our argument, you really want to sync that transition up with testing capacity. So I gave you that 5 million tests a day as an aggregate number for the entire country. As you know, the essential workforce has been open this whole time. That's already 40% of the workforce. So actually ensuring safety for people who are already out and about moving around would really require a level of testing at about 2 million tests a day, coupled with contact tracing. Where does that number come from? That's the number that we have identified as what would constantly decelerate the disease at a sort of reproduction number of 0.75. So people have heard a lot about reproduction numbers. That's the rate at which any given infected person is infecting others. How many other people do they infect? When that number is above 1, you have exponential growth. You're trying to get the number below 1. In our modeling, we targeted an R of 0.75 to put the virus on a steady downward course. So we ought to be really running really robust testing and contact tracing programs already. Massachusetts is stepping up. The number is increasing. So what you really want to do is make sure that the targets for testing are in sync with the percentage of your economy, of your workforce that's actually active and moving about.
Yeah, we have that 1,000-person contact tracing program already up and running, and that will probably expand as we go. That's the program where people who are testing positive for the coronavirus say, well, here's a list of the people I've been in close contact in recent days, and then the tracers attempt to reach those people to help sort of contain the virus even more. We're talking about the societal costs of COVID-19 and what the path out of this pandemic might look like. Our guests in this virtual WBUR Town Hall are Dr. Sandro Galea, Dean of Boston University's School of Public Health, and Danielle Allen, who directs Harvard's Edmond Safra Center for Ethics. And viewers, you can submit your questions at slido.com using the hashtag WBURVTH4. And let's get to some of those questions. Megan asks, are there unintended risks to prolonged lockdown? I worry about my young children and their inability to go to school. How will this affect them in the future? Dr. Galea, let me put that question to you.
Yeah, I think there are, unfortunately, we're in a situation where there is a risk to everything we do. I think there's a risk to premature opening. There's a risk to prolonging lockdown. So let's talk about children. Children are missing school. Children are missing school. They are missing formative years. They are missing developmental milestones. Children who are seniors in high school are missing years, which otherwise, a time when otherwise they would be learning things that are actually important as they move to the next phase. Seniors in college are graduating in a time when the economy is not robust, and we know that puts them on a trajectory of poorer lifetime earnings. So there are a lot of consequences. The other set of consequences to put on the table are the mental health consequences. We know that after traumatic events, and this is a traumatic event is an event that is shared collectively, that threatens our sense of physical or mental well-being. There is an increase in mental health problems broadly, things like anxiety, depression, more use of alcohol, more use of cigarettes. And those consequences are shaped in no small part by social isolation, by people being lonely, people being by themselves. So there are real costs in terms of kids. To go back to the question, I do worry about young kids. I worry about their mental well-being, and I worry about their stimulation and their social and psychological development. So these are all risks. Now, these risks have to be balanced with a plan to reintroduce us into society in a way that does not incur the return of the virus in a large scale, which would then require, again, closure. So I'm very much in agreement with Professor Allen and with the plan she articulated. It seems to me that the rational way forward is testing, contact tracing, and isolation that is implemented across the board. And the 5 million number of tests daily is roughly reasonable from all the other estimates I've seen. And, one can always estimate these things with a million here and there. But broadly speaking, the urgent national priority is to scale up and have available tests that are affordable, that can be used across the board, and systems in place for us to contact trace. Once we have that in place, we can have graded re-entry with risk stratification. That means being careful about those who are most at high risk, which we know in these situations are people with underlying diseases and people over certain ages. Once we have that available to us, we can really have much more confidence that we can test actively, contact trace as needed, isolate people who need to be isolated, and we are protecting people who are most at risk, mitigating the consequences that will inevitably accrue the longer we prolong the lockdowns.
It's tough to balance, though, right? The competing interests there, Dr. Galea, because as you talk about sort of the mental health aspect of this and what students are missing on, I'm thinking about those high school seniors, for example, and all the sort of fun end of their K-12 education milestones that they're missing, proms and whatnot.
Yeah,
I don't want to be dismissive of that. I mean, there's real value to those things, and yet gathering all those young people together, even if they're more resilient to the virus than older populations, they go home to parents and grandparents, right? I mean, this is a tough thing to balance.
It's hugely tough thing to balance. It requires a mature conversation that weighs the risks and the benefits. And I actually think we owe it to ourselves to have this kind of conversation nationally. I mentioned earlier in my earlier comments being disappointed that we have not been having that conversation nationally. And the reason I agreed to come and have this conversation is because I was pleased that WBUR is hosting this kind of conversation, because there is no easy answer. I mean, it's not so straightforward as we can apply any number of economic models and weight quality of life in any number of ways, but ultimately it comes down to balancing values and balancing priorities. And those are not balances that lend themselves to a simple mathematical reduction. They require a balance of priorities, and they require mature judgment about which one is the right priority at the right moment in time. So you're going back to the article you cited, where I said in there, we've done a lot of things that we had to do. So in my estimation, doing the shutdown orders at a time when we did not understand what was going on with the virus, where the urgent imperative was to mitigate the spread of the virus so as not to flood our healthcare system, was the right thing to do. That was the right thing to do at the time. That does not mean it's still the right thing to do today. It does not mean it will be the right thing to do 2 months from now. And that requires conversation. It requires constant conversation about the balance of forces, about the risks of maintaining shutdowns, the risks of loosening up. And I think Professor Allen's prescribed approach, which is a careful, measured reintroduction that is accompanied by abundant testing that we are constantly monitoring and picking up cases very quickly, contact tracing and isolating those who may be spreading disease, so we don't go from clusters to outbreaks to epidemics, is the way to go.
Well, Professor Allen, let me bring you back in, because as you might guess, we're getting several questions related to children and the reopening process. And I'll just pick one that kind of represents a few, and I'd love to get your take on it. Vulnerable kids are losing access to quality education, just one cost. Why not require more stringent distancing for vulnerable populations and less for lower risk populations? Is that possible, or is that really hard to execute?
It is hard to execute. I mean, at the end of the day, Dean Galea is correct that what we're aiming for is risk stratification. As a society, we're also aiming for restoring a sort of tolerable risk profile for our whole society, right? And so that's the thing that we kind of need a collective conversation about. This is work that we should be engaged in with a sense of common purpose. In that regard, it's not really about pitting this interest versus that interest. We unfortunately suffered an attack from a virus that produced a situation in our country where we are not actually able to secure reasonable sort of levels of risk for significant portions of the population. It's our job as a society to deliver, in the words of the Declaration of Independence, institutions that can secure safety and happiness. And what that typically comes down to is the idea that we run our institutions and we set up policies in such a way that the risks that people kind of run going about their lives in an ordinary way are tolerable. We make our own judgments about whether to drive on the freeway where the speeds are really high or only to go on sort of slower moving roads in town and so forth. And so that's really what we need to get back to here with this disease, is a world in which people can make reasonable judgments about a reasonable level of sort of possible risks that confront them. So I do think that conversation about shared purpose is really important, because yes, lots of people are being asked to sacrifice as we work together as a society to achieve that. And one really needs that frame, I think, in order to engage in these conversations. So it's absolutely sort of a key sort of possibility. There will be ways in which we are going to be sort of stratifying and protecting more vulnerable populations without any question. But at the end of the day, vulnerable populations are sufficiently sort of interwoven through the entirety of our social fabric that we can't actually pull a community apart for perfect protection. And so they're currently, with current levels of disease, they're just really such sort of high vulnerability that we wouldn't actually succeed if we had the best of intentions of sort of trying to always stay apart from older people in our community, or always stay separated from children who are immunocompromised or something of the sort. The odds of actually building a kind of impermeable boundary of that kind are really low. So in that regard, our collective mission, our common purpose, really does need to be about restoring reasonable levels of risk across the whole of our society.
Let me just pull out one example, because Boston is such a hub of higher education, and of course you both work on college campuses. I mean, what are you guys thinking about as we look ahead to a fall semester? I know that Dean Galea, BU has already moved to sort of a hybrid model on campus and some remote learning for graduate students coming in the fall. I mean, what should we expect? Students back on college campuses? Some, all, none? What are you thinking for the fall?
Yeah, let me say one thing about risk to echo what Professor Allen said, and I'll talk about universities. Ultimately, we are dealing with finding levels of tolerable or acceptable risk. But we do this all the time as a society, and we should be very clear that having a conversation about finding tolerable risk around coronavirus is not that different than what we do when we decide. I like Professor Allen's example of speed limits. I was actually going to use the example of motorcycle helmets. We decide as a society that the risk of driving a motorcycle without a helmet is not tolerable. So we come up with helmet laws. I mean, we decide on speed limits. We come up with speed limits. We decide that the risk of driving a car without a seatbelt is not tolerable. So we have seatbelt laws. So ultimately, we do this all the time. And I think in the coronavirus discussion, perhaps because it's been so new, we have lost sight of that what we are talking about here is coming up with a tolerable risk framework that balances living with the coronavirus with living our lives and allowing our society to flourish the way it should. Now, let me talk about college campuses, because in some respects, it's an extension of this conversation. The conversation on college campuses that's happening is, how can we make sure that we do not interrupt students' educational trajectories, while, of course, balancing that with the risk and making sure that we keep students and faculty and staff as healthy as possible. The general plan, which I think most colleges in Massachusetts and Boston will go to, will be a plan to reintroduce classes in a hybrid format, which means that some students will be taught in person, some students will be taught digitally, to have fewer people physically in close proximity. And by having a hybrid format, it creates the opportunity to stratify risk, meaning to say those who are at higher risk, who do not want to be around other people, can still do their learning, but do it remotely, while those who are at lower risk can do it all together in the same place. Now, that is predicated on the underlying assumption that we will have the capacity to test. They will have the capacity to test, to contact trace, and to isolate quickly. Because if we combine that with a risk stratification approach and re-entering into classes with a hybrid format, you can see why that actually creates a safe environment within a level of tolerable risk, to use that term again. We are saying essentially, how can we make sure college campuses are as safe as possible, given the fact that the coronavirus is around and it's going to be around for some time? Make sure that we're not interrupting people's educational trajectories, but also not exposing anybody to unnecessary risk, be it students, be it faculty, be it staff.
Professor Allen, let me just pull in another question that's coming in here on Slido, and I'll just summarize it because it's related to this. We have seen an uptick in recent days of anti-lockdown protests in some states, including our own. We had a big crowd of people at the State House yesterday. So I think the question that kind of comes with that is, do we risk sort of shooting ourselves in the foot the longer these restrictions stay in place if there's a backlash and people rebel against them?
So this is the place where I think political leadership is just the most important thing. And I think the work our governors are doing is extraordinary across the board. But basically, the folks who are protesting have a legitimate concern. They're pointing exactly to what Dean Galea sort of pointed to in the beginning. That is, collective lockdown or collective stay-at-home orders, collective quarantine was a reasonable, immediate emergency response. It is not a tool that you can use over the long term for disease control on a national or global scale. It just isn't. So they are raising an appropriate question. And it's good, in fact, that they're mobilized and engaged by the questions that face our country, the most pressing questions. But what political leadership ought to do ought to be to direct that energy, to guide it, to support it, to encourage that energy in the direction of engaging in a project of shared common purpose. And so that's what we're not seeing happen. And that really is, from my point of view, a tragedy. So early in the crisis, I wrote about how this was, we did have to see ourselves as, in some sense, being on something like a war footing. That is, there was a sort of surprise attack from a virus. It's sort of an invisible enemy. It's not a real war. It's not against any other country or anything of the sort. To the contrary, actually, humanity is all together in this war against the virus. But in that kind of way, we actually needed sort of whole society mobilization, and we needed real clarity. We needed sort of real public conversation about what our common purpose should be. And our common purpose, I think, ought to be saving lives and livelihoods together, finding the tools and strategies that permit us to do that. So again, I think it's a very painful thing that our political leadership is not helping all of us collectively focus on a shared objective.
Well, Dean Galea, I think one of the things that makes that sense of common purpose hard to achieve is the reality that we're not all bearing the cost equally here. I think you mentioned something along that line earlier. We're seeing some inequalities exposed through this pandemic. For example, folks who have maybe higher paying white collar jobs can probably more easily work remotely than folks who have hands-on blue collar jobs who need to be in the workplace and perhaps taking on higher risk. Even in the home, we see the legacy of redlining in some neighborhoods where it's really difficult for people to maintain physical distancing guidelines. So it sounds really great to say we're all in this together, we all have a common purpose, but the reality is there is an imbalance here, isn't there?
Yeah, there is. So let's start with the politics and leadership, echoing Professor Allen's comments. I had a piece that was published a couple of weeks ago, which I think the title was "The Virus Will Not Kill Us, the Politics Will." And what we meant in that piece was exactly what Professor Allen said, that the virus obviously is a threat, but we as a humanity deal with threats all the time, and we have dealt with threats. And what has been disappointing in this particular case is that there hasn't been political leadership at some levels that has helped guide us through these competing impulses, that has helped guide us through saying, how do we balance pros and cons of maintaining stay-at-home orders, of starting to reopen society? And we ultimately do need that as a way to referee the various inputs that we are seeing now being manifest through some of these protests. So that's number one. I think in terms of sort of moving us forward and in terms of thinking ahead to where we take this, we ultimately need to come to a place that says, okay, we understand the consequences, and we understand that those consequences affect all of us. Now, how about this issue, Callum, that you mentioned of imbalance? That, frankly, the consequences are less. They are fewer consequences for the three of us on this conversation than they are for millions and millions of Americans. And how do we see that as our collective responsibility? So I think there are two ways to think about it. Number one is, ultimately, we need to come to see health as a public good. Health is a public good that we should invest in collectively. We should be thinking of health the way we think of the post office, of fire stations, of the environment, something that we invest in collectively because it is a standard that we would like to achieve in our society. That's number one. That's at the level of principle. Now let's get more pragmatic. Well, infectious diseases present the most pragmatic case for thinking about the health of all as being inextricable from the health of a few. Because if there are reservoirs of disease in particular groups, they put everybody at risk. So if there ever was a time to say that our health is inextricably intertwined, that my health and your health are interlinked, it is now. That's why we wear masks. That's why we do physical distancing, is because we are healthy together or we are less healthy together. So I suppose, Callum, I think we need to appeal both to higher purpose, to shared purpose, to say health is a public good and we have a moral responsibility to protect the health of all. And well, if that higher purpose is not enough for you, then let's look at a purpose that advances your health, and your health is not helped if my health is at risk. So I think the two together, what I'm hoping, are going to bring us to a place where we recognize once and for all that health equity is a central part of health, that we cannot have a society where we have substantial numbers of health left behind. We have a moral responsibility and a practical purpose why we should not accept that.
There's a related question coming in via Slido, Dr. Galea, and I just want to remind folks you can submit your questions at slido.com using the hashtag WBURVTH4, as in Virtual Town Hall number 4. And this sort of goes along the theme of what you were just talking about. How does the narrative of us versus them playing out in some parts of the nation factor into this, Dean Galea? Yeah. Like increased hate crimes towards Asian communities, for example?
Yeah, I find that deeply distressing and very saddening. And unfortunately, and I don't mean this as a partisan comment, but I do mean it as a political comment. There has been a national conversation of division. There has been a national conversation of division for the past several years, where particular groups, particularly immigrants, particularly minorities, people of color, have been scapegoated for all sorts of things nationally. And that, one can look away and say, well, it doesn't affect me. Well, we're now at a place where we're saying it affects all of us, because that kind of language of division, that kind of a divisive approach to our politics that pits one group versus another, has calamitous consequences at a time when we need shared and common purpose, at a time when our health is interlinked. So I think citizens of good conscience everywhere have a central moral responsibility to say no to divisive politics, to the politics that others groups, to the politics that says you as an immigrant are lesser than those of, quote, us who are natives. That is, first of all, should be reprehensible at the level of principle. And again, leaving aside principle, at the level of pragmatics, that is endangering our collective health. And that is endangering our collective health when it comes from the president as much as when it comes from people on the street talking to each other.
Professor Allen, let me see if you can help us find a silver lining here as we think about moving forward. We keep using this phrase a lot, getting back to normal, trying to get back to normal. That's a really attractive idea for people who really liked their old normal, but I think it's worth remembering that the old normal was not so great for a lot of people. And so I'm wondering whether there's an opportunity here in this pandemic as we chart a course out of it to get to a place where society is actually better and fairer than it was before.
Well, you're a business reporter, so let me use a business analogy. The economy in 2008 was vulnerable to financial shocks. There were various features of the global financial system that people had not fully understood or tracked, and consequently we had a huge meltdown from massive credit leverage nature of the economy and so forth, securitization and on and on. And after that global meltdown, we went about the work of restructuring key features of the financial system in order to make financial stability one of its basic elements, sort of foundation building block. And something similar is our current situation. That is, as of December 31st, 2019, the global economy, integrated though it is, was not pandemic resilient. That is, it did not have the capacity to handle rapid spread of an infectious disease other than through national scale collective quarantines that produced the biggest economic shock since the Great Depression, as we know. So the near-term response, the thing that we actually have to do to get out of this crisis, is actually also what we need for long-term pandemic resilience. That's why we put that concept at the core of our roadmap. So we are in a globalized world. We have a globalized economy. We're not going to move away from that because its value for delivering prosperity is just too significant. If we fully contracted within our own walls and tried to wall off the rest of the world, our own prosperity would diminish. So we are going to live in a globalized world. We're learning in some sense, it seems like every decade, another feature of what it actually means to have an economy that can thrive in a fully globalized world. So what we've learned with this crisis is that an economy that's going to flourish in a globalized world has to be pandemic resilient. And what does that mean? It means that we have to build in exactly the kind of health infrastructure that Dean Galea was talking about. We are not pandemic resilient because we have underinvested in our public health, county public health offices across the country. We are not pandemic resilient because we have this sort of hugely disparate provision of health resources across the country, leaving many people in our population more vulnerable to this disease than they needed to be. And as they are more vulnerable to this disease than they would, sort of strictly speaking, necessary, that makes us all more vulnerable because the disease could get a foothold and spread much more rapidly in this country than other countries where there was a higher level of basic healthcare provision. So you take Germany as an example. Germany has a lower infection fatality rate because they have higher levels of general healthcare provision, as well as more surge capacity in their hospitals, better triage protocols in their hospitals, things like that. So what we've learned is that sufficient provision of healthcare, sufficient investment in our county level public health offices are actually part of what we need for a healthy economy, for an economy that won't suffer a shock when a novel virus emerges in some other part of the world. So there's learning in this crisis. That's the silver lining. And the very things we need to do to respond to the crisis should leave this economy much more pandemic resilient going forward than it was as of December 31st, 2019.
guess the question is whether we apply those lessons going forward, right? But you say there is some learning going on. We're talking about the societal costs of COVID-19 and what the path out of this pandemic looks like. Our guests at this virtual WBUR Town Hall are Dr. Sandro Galea, Dean of Boston University's School of Public Health, and Danielle Allen, who directs Harvard's Edmond J. Safra Center for Ethics. And a reminder, viewers, you can submit your questions at slido.com using the hashtag WBURVTH4. All right. The cost for almost 900,000 people in Massachusetts has been a lost job. And I've put together a chart that I think illustrates just how unprecedented the economic fallout has been. So initial unemployment claims in Massachusetts spiked dramatically in mid-March. They started to taper off last month. And then when gig workers and the self-employed became eligible for benefits, filings shot up again last week or in a recent week. So for perspective, we just had a week toward the end of April where you had more unemployment claims, 10 times more unemployment claims than the worst week of the Great Recession. So really, really stark uptick there. And even with these expanded unemployment benefits, a lot of people in our state are worried and struggling, which brings me to another good question from a viewer who writes, I'm in a low-risk group for COVID health outcomes, but a high-risk group when faced with potential economic fallout. Why can't I go to work and feed my family? Professor Allen, what can you say to this person?
Well, I think that you should be able to go to work and feed your family. And I think that every level of our government should be working as hard and fast as it can to deliver the testing capacity that we need to ensure that our health structure is stable and that we're reducing the spread of the disease. So in other words, the trouble is that if we don't have that disease control infrastructure in place, then as people go back to moving about the economy, the number of diseases and cases will increase again, putting burdens on our health system, generally undermining the sense of stability of our institutions and legitimacy of our public authorities. So we have a really deep societal problem, really deep problem to solve. I think for me, the thing that's painful is that there is a solution that would permit you to be back in the economy, that had we moved quickly in February to really pull the supply chain together for testing in the country, you could be back in the economy now. So I guess I want to say it really isn't an either or. There is a solution. And so every one of us really has to be sort of calling our legislators, calling the governor's office, calling Congress, calling the White House and saying, speed it up, folks. I mean, this work can be done. There are no laws of physics that have to be broken to deliver the level of testing and disease control that we need.
The cost, though, Dr. Galea, isn't always as tangible or as financial as somebody losing a job. I know that you've written about mental health. And so I want to give you another viewer's question who writes, I feel like this social isolation is never going to end. I'm depressed. Life doesn't feel worth it if this is what it looks like. When will this be over? How would you respond to that, Dr. Galea?
Well, there are many answers to that. Let me start by expressing sympathy for the viewer who sent that in, and a strong recommendation that any viewer who feels that way should talk to a healthcare provider. I think there are any number of ways in which one can do that. Obviously, through through your insurance plan, there you should be able to be connected to an insurance provider. If you don't have an insurance plan, there are many ways on the web to get connected to providers who are willing to actually talk, even if you're not covered by insurance. So number one, at the very personal level, I would want to make sure that anybody listening to this who feels that life is not worth living and or feels that they are depressed in a way that is not allowing them to function, they actually talk to somebody about that. So it's number one. Now, let's take a big population perspective. You said, Callum, that there are other costs than the economic costs, and mental health being one of those costs. I actually think that mental health is inextricably bound with the economic costs. So we know that stressors, be they financial stressors, having a hard time paying the mortgage, having a hard time with school for your children, having a hard time with your spouse, having a hard time helping your elderly parents, those stressors are precipitants of mental health problems. We know that people are more likely to have mental health problems if they have those stressors, and we know that people with mental health problems, with those stressors, are likelier to continue having mental health problems. So the two really are inseparable. So it's not a matter of saying, well, there are the economic consequences and the financial stressors on one side, and there are mental health problems on the other side. The two really are part and parcel. Treating the economic problems that we're facing right now, and by the way, those unemployment numbers are horrible. This is, saying things in one sentence that is more cases of unemployment, 10 times more than there was during the Great Recession.
Yeah.
I'm just repeating that because that sentence is behind it. There is an extraordinary amount of human suffering. And so we cannot simply sit here and say that is tolerable, that is acceptable. It simply is not. That we can and we should do better. And I agree completely with Professor Allen, who said it is perfectly reasonable for somebody to say, I want to go back to work, and it is our collective responsibility as a society to make that possible. And in so doing, by the way, we are also mitigating the mental health consequences. So to summarize on mental health, number one, mental health problems are really the second wave of the epidemic. And we know this is the case after any range of other mass traumatic events, after hurricanes, after earthquakes, after terrorist attacks. After the immediate threat to physical self, there comes a wave of mental health problems, which typically is depression, typically anxiety, post-traumatic stress disorder. That wave can be disabling for months and years. So number one, we need to talk about this. We need to be aware and alert to it and have the conversation so that anybody who thinks they are having symptoms that can benefit from help can talk to somebody. So number one is education. Number two, it is creating the opportunities for people to have someone to talk to who can actually give feedback and say, well, what you're having is you're a little bit sad, you're a little bit anxious, but that's fine. That's actually normal in this context. Or to say, no, what you actually have should be seen by a therapist and could potentially benefit from treatment. And the line between the two, just for any viewer who is wondering, is typically we say something is an adjustment to difficult times if you're still able to function, you're still able to meet your personal and professional obligations despite feeling a bit sad, feeling a bit anxious. But if your sadness becomes you're sleeping all the time, you're eating all the time, you're not eating at all, you cannot function, you're too anxious to actually do your work, you're too anxious to interact with your family members. So if these symptoms are getting in the way of your personal and professional function, then those symptoms would benefit from talking to someone. So I really have enormous sympathy for all of us. It is not us and them, this is all of us. This moment in time is a real recipe for mental health challenges. We should be aware of it. We should be talking about it. We should be doing everything we can to restore economic function, to minimize financial stressors, and at the same time, making sure that there are resources in place for those who need them because of mental health problems right now.
Well, related to mental health, Professor Allen, we've got a good question coming in on Slido just now about people, places that violate the guidelines on social or physical distancing, and churches comes up here as an example. So what about folks who are gathering in houses of worship? It's good for their mental health. This is part of their routine. It's a meaningful activity for them, but they're breaking the guidelines that public health officials are outlining for them. What's your take on that, and how should the rest of us think about that?
So I would like to encourage people to pay really close attention to questions about what the rate of prevalence of disease in their context is and the official guidelines they're getting about that. Because basically, if you are in a high prevalence context and you're participating in a mass gathering, you may well be facilitating infection and facilitating harm to the people you love, as well as to your broader community. So this is where, again, fighting an infectious disease, it really is a collective endeavor. And what we are trying to do is achieve control of the disease so that people can make reasonable judgments about risk. But the risks that we're making judgments about are not just risks to ourselves, they're also about the risks that we carry to other people. And I think this is one of the hardest things with this disease. There are so many asymptomatic carriers of the disease. The estimates range from about 25% to 40% of people who are infectious and passing the disease on don't have any symptoms, okay? This is the thing that makes COVID so hard, makes it harder than influenza, makes it harder than any number of other diseases. And so the problem is a person can actually feel perfectly fine. They can be perfectly fine and they can be infectious and they can go around the world and give COVID to another 10 or 15 people. And then that really can produce an outbreak very quickly. So that's why we've seen the dynamics that we've seen. So until the overall prevalence is low enough that the odds of a person doing that are really low, it's just not really fair to one another, actually, to put each other at risk in that way by participating in mass gatherings, even religious ones. I'm a church-going person. I can tell you, like, it is extremely painful not to go to church. I absolutely feel that. I feel the missing my community every week. I feel the distance and the lack of connection on that. I get it. I 100% get it. But the fact of the matter is, because of that number of asymptomatic carriers out there, until the prevalence is broadly low, it's just not really fair to ourselves or one another to do that.
You know, Dean Galea, I want to ask you about something you mentioned earlier when you talked about physical health. And of course, there's the physical effects of the disease itself, but you mentioned the physical health consequences of an economic recession when people are unemployed. Could you fill in some more details on that? I mean, what do we know about the physical health consequences of an economic downturn? And then how should we factor that into the decisions we make about how and when to reopen?
Well, the way to think about that is to shift our conversation from thinking there is a divide between mental health and physical health. Mental health and physical health are both health. Mental health ultimately is a neurochemical imbalance in one particular organ, which is the brain. And it's an organ like all other organs, like the heart, like the liver, like the kidneys are organs. So the divide between mental health and physical health is more of a sort of nosologic historical divide than it is a real divide from an organ system point of view. So that's comment A. Now, we know through abundant studies, for example, that if you're depressed, you are more likely to have heart disease. If you're depressed, your heart disease is going to be worse. If you have post-traumatic stress disorder, you are more likely to have any range of diseases, including, for example, diabetes. So diabetes is one of my favorite examples. We know that diabetes is highly prevalent in this country, linked very much to obesity. But anybody who has experienced a traumatic event and who has had post-traumatic stress after a traumatic event is quite a bit more likely to have diabetes than somebody who has not experienced a traumatic event, as in had post-traumatic stress. And we can talk about why that is. There are many shared biological pathways that explain that. But the bottom line is that the physical health manifestations are not separable from the mental health manifestations. So Callum, you're asking about what are the physical health consequences of economic downturns? And the short answer, actually, there are not many conditions which are not linked to broader social and economic forces. There are some conditions that are very heavily genetic, which are not responsive to social economic forces. For example, pancreatic cancer. Pancreatic cancer is a good example of something that is quite rare and it is not socially patterned. But most of our health conditions are socially patterned and they are responsive to social and economic forces. Let me give you another concrete example. After 9/11, there was a rise in all sorts of cancers. Now, cancer doesn't happen right away. Cancer has a long latency period. It takes 10 plus years for a latency period. And that's exactly what was seen after 9/11. Things like heart disease can have a shorter latency period. You know, the major killers in this country are heart disease, cancer, neurological disorders, things like dementias. And then you get into accidents and injuries. All of those are affected by social and economic conditions. All of them are socially patterned, and all of them will increase after significant economic and social stressors. Now, what's unusual about this moment is the following. Number one is there has been a trauma collectively experienced, and by collectively, it is across the whole country. I've been studying mass traumatic events and disasters for the past 20 years. I've studied 9/11, Hurricane Katrina, Hurricane Ike. I've studied wars. I've studied soldiers who've been in Iraq and Afghanistan. But this event is unique among all of them in that it's a trauma that's affecting everybody. It is a trauma of the virus and the worry about the virus, accompanied by the trauma then of a massive economic recession. And that really frightens me. That really frightens me about the full burden of mental and physical health challenges that we're going to face. So to echo something that Professor Allen said, I think if that is not a real rallying cry to anybody in a position of authority, anybody who can make change happen, to say, this is imperative that we are all hands on deck on getting the economy started to relieve financial and social pressures from people as quickly as possible. I don't know what is, because this will be an enormous setback in our national health.
Well, Professor Allen, we're talking about physical health and mental health, and a viewer is reminding me not to forget about cultural health. You know, staying isolated the way we have can really wear on the fabric of our city. And so a viewer asks, what should city officials do for our independent cultural institutions right now? How can we support struggling venues, artist communities, and creative pillars? What do you say to that?
So it's an important thing to pay attention to. And so I think communities of support, audience goers and things like that for cultural venues, when they are able, if they're in fortunate positions, ought to be able to think about their philanthropic commitments and actually increase them, or folks who are subscription holders for theater or whatever else. I hope you haven't asked for a refund if that was something that you could avoid having to do. So we have the effort of the national government, of course, to provide support to tide over businesses, but also actually they're providing support to cultural institutions too. So as I understand it, I think the NEH received some funding in some of the packages that have gone through, the reserve recovery packages that have passed through Congress. So there is a way to think about providing support. In the context of 9/11, major foundations in New York provided emergency funding packages for networks of cultural organizations, and I believe they've done the same thing. I know the Carnegie Corporation has made a major commitment to investing in cultural organizations in New York. So I do think that the philanthropic community has a specific role to play when it comes to ongoing support for cultural organizations in moments of this kind.
Let me try to get to a few more Slido questions from viewers while we still have time. What changes that we make today will remain long after we develop a vaccine for COVID-19? Shaking hands, large group gatherings, large classes, and whatnot. Dr. Galea, let me put that to you. I like that first. Are we going to keep shaking hands, or are we going to be permanently elbow tapping even after we have a vaccine?
I like shaking hands. I hope we go back to shaking hands. No, I think once we have a vaccine, I actually think there's no reason not to shake hands. But I do think there will be changes that will become permanent, and I think that's okay. I think there's a moment for innovation. We talked earlier about universities, and a lot of universities moving to teaching courses in a flexible way, in a hybrid way. I see no reason why that doesn't become a new normal, why we do not learn from the use of digital technologies, and we do not create opportunities for flexibility in how we teach and how we learn. I see no reason why we do not learn in changes in the workplace that, again, are capitalizing on digital opportunities to create ways in which we can work that are more flexible and perhaps more suited to people's various needs, that allows them to work and weave work in around their lives. I would expect, to go back to cultural institutions, that there will be changes in arts and culture, some of which will also be innovative and some of which we'll want to keep. So I think this is an inflection point, and we should respect it, and we should learn from it, and we should keep from it the good. In my world, and we talked about this a little bit earlier, I would like us to change how we talk about health from this moment. To elevate the importance of health as a shared value. Can you imagine any other reason why we would have upended the world the way we just did over the past couple of months other than health? I mean, if that doesn't reinforce how much we value our health, I don't know what does. So if we can recognize that, and recognize that health and the promotion of health for all groups, equitable health for all groups, should be at the heart of what we do, I think if we can do that, and we can keep that in mind, and when we are in future making decisions about transportation policy, about housing policy, about financing, about taxation, say, how does this affect our health? How does this protect us if there is another pandemic? I think if we can do that, we'll actually be better off for it. So I think these changes are positive changes. Coming down to sort of the more mundane, about shaking hands and greeting relatives and having shared collective dinners and being in restaurants where there is conviviality and going to Broadway shows and going to sporting events, I hope all of those come back, and I see no reason why they will not.
So we're running a little bit short on time, and I want to try to pack in one more viewer's question that I think represents, we've heard some skepticism or some frustration about the restrictions coming through in some of the questions tonight. And I want to give you a quick chance to address some of that skepticism about expert guidance. So a viewer, Dr. Allen, writes, we're flattening the curve to avoid overwhelming hospitals. Hospitals are not overwhelmed, but closures continue. So how can I trust our leaders? I feel misled, says this viewer. And I'll just throw in one more example, Professor Allen, because tomorrow we have that statewide advisory on wearing face coverings going into effect. And of course, health officials initially did not recommend that we wear face coverings. That guidance has changed. So what would you say to folks who are questioning, whether they should continue to adhere to expert guidance?
So, I mean, it's a great question, and that is one of the hardest things. On the masks, let me start with that, actually, because I think it's a good way into thinking about the question generally. So what happened with masks is that when the crisis hit, the folks at the CDC recognized that we did not have enough masks for healthcare providers. So focusing on one question specifically, the need to ration the supply, they gave out the guidance that people shouldn't wear masks. This was a really, from my point of view, unfortunate moment. It failed to educate the public broadly about the value of mask wearing, the fact that precisely because of that asymptomatic number that I mentioned, people can be unwitting transmitters of the virus. So mask wearing is in fact quite critical to stopping transmission of the disease, and every successful society that has managed to control the disease has really pervasive cultures of mask wearing in a context like this. So Taiwan, South Korea, Germany has been really strong on masks. So, I think they made a mistake. And so I completely understand where a person is coming from. I say, well, why should I trust what I'm hearing from the CDC and so forth? So unfortunately, I don't think that there is a good answer to that question. I think that, a lot of people at universities have been working really hard to get good information out of some frustration with the fact that there has been uneven provision of information from the CDC from the start. So I think the good news is that the information is getting stronger and better and also more consistent. So if you really sort of dig deep and look across policy making shops, across colleges and universities and across the CDC, the messages are now coming into alignment with each other. So I think that's probably the best evidence there is that the knowledge and understanding in the expert community has taken a real leap forward in the past 2 months. I think the thing to say is that experts, just to say somebody's an expert doesn't actually mean, as everybody knows, that they know everything, right? No. And basically, this has been, I think, one of the steepest learning curves for policymakers, for infectious disease experts, et cetera, everybody for the last 3 months. And so people made mistakes. They just did. And I think that needs to be honestly acknowledged. They have, however, been working really hard climbing that learning curve, that incredibly steep learning curve. And again, I can see the improvements in the quality of knowledge across the board.
And just in the moment that we have left, Dr. Galea, last word to you. Still a good idea in your view to follow expert guidance, even if it's imperfect?
I echo Professor Allen. I think mistakes have been made, but one hopes that in the big picture that the body of people who are in positions of authority who are trying to make decisions are trying to make decisions in good faith, taking the best possible evidence and trying to make reasonable, rational decisions, understanding the challenges that we are under. My sense is that we have gotten better. My sense is that expert evidence is converging. It'll be very difficult, I think, today to have two experts on a show like this who do not agree that testing, contact tracing, and strategic isolation with some sort of risk stratification is not the way to go. I think opinion has converged on that. And I would encourage any listener to sort of look carefully across a range of recommendations, across a range of what experts are saying. And I think in Massachusetts, which is where we are situated, I think we have been fortunate. We've had really careful, responsible governance that has tried to balance a number of really difficult forces, a number of difficult inputs, and come up with guidance and regulations that are trying to protect us from the urgent threat, and hopefully now transitioning to a place where we're dealing with the important short, medium, and long-term challenges that we are all going to face together.
All right, we're going to have to leave it there. We've run out of time in this hour, but Dr. Sandro Galea, Dean of Boston University's School of Public Health, thank you so much for joining us tonight.
Thank you for having us.
And Danielle Allen, Director of Harvard's Edmond J. Safra Center for Ethics, our thanks to you as well.
Pleasure. Good to be with you, Callum.
And viewers, we're grateful for your participation and great questions tonight, too. And if you missed any of tonight's discussion, a recording is going to be available at wbur.org/events, along with the 3 previous events in our virtual town hall series. I'm Callum Borchers, and I hope you'll join us again next Tuesday at 6 when WBUR's Barbara Moran leads a conversation about climate change and how addressing it could help prevent future pandemics. Until then, stay healthy and have a good night.